So we are going ahead. Can you hear me now?
Yes, sir.
Yeah. We are going ahead with the infraclavicular block, and now we are coming from the supraclavicular to the infraclavicular. Here there are going to be divisions from to the cords. So we have the trunks, we have the divisions, and now we are moving from the clavicle, below the clavicle, towards the cords. So the cords, as I told you yesterday in the workshop, it can lie at various levels, not necessarily very close to the axillary artery, but it can lie at various levels. And we'll try to locate few of these cords. Now the landmark is the coracoid process, and you go 1.5 to 2 centimeters medial, and then the same distance inferior. So 1.5 to 2 centimeters medial, and then 1.5 to 2 centimeters inferior. And here you insert your needle. It should go vertical. It first goes through the pectoralis major. You see a pop. You go through the pectoralis minor. You see a pop. And then when you turn your nose stimulator, then you might have some contractions which may be related to the lateral, posterior, or the medial cord. The first one to encounter is the lateral cord, and eventually you will come across the posterior or the medial cord. We can turn it later on. So, can you see the needle?
Yeah, we can see your needle. Yes.
Yeah. One small prick. Yeah. So we are going through the pectoralis major, and then through the pectoralis minor, and then we'll try to try to increase the stimulation. Yeah, that's fine. And now we'll try to locate at the level of the cords. Can I decrease this? It should be quite superficial because he's a thin patient.
Yeah, I think we can feed now.
Yeah. Can you show the twitches? Finger. Can you see those twitches?
Yes, we can.
They are the flexion of the metacarpophalangeal joint, and it means that the median nerve, either the lateral part of the median or the medial part of the median or the median nerve itself, which forms or the medial cord. That's and you're getting at 0.7 milliamperes. You can still come down.
You can see two twitches.
The 0.6.
SNSE.
Yeah, what is that? SNS?
It's a double twitch.
Double twitch. Okay. No, I'm not used to this HNS. Yeah.
0.5.
No.
You want to go to 0.2?
Yeah. So small manipulations do matter when you are giving the infraclavicular block, and it's very important at zero point 0.4 milliamperes you get these contractions. You can see the adduction of the thumb also, and you can see the flexion. So it's very close to the median and the ulnar nerve. And at this point, if I leave the needle on itself, it doesn't, but it requires a very small manipulation when you can get those contractions. So you need to be very, very careful when you're giving this infraclavicular block, because this is only one injection technique, that is single neurostimulation, where you're going to give the drug, and the dose is again 0.5 to 0.6 ml per kg body weight. Can you just increase a bit? Okay. Can you just attach the syringe? So at 0.48, if you can get those contractions, then you can see now the needle. See, the needle was directed actually vertically, but then you have to reposition your needle. You can inject, madam. You can aspirate and then inject slowly. And once this starts injecting, there should be disappearance of the twitch. You're getting some resistance? No. Don't pull, don't pull, don't pull. You're pulling this. Yeah. So that's the disappearance of the twitch. You can go for the middle cord response, and as I mentioned yesterday, the musculocutaneous nerve, it comes below the point of the needle insertion. So the musculocutaneous gets blocked, and hence the forearm, all the cutaneous branches to the forearm, they do get blocked in this. And the dose here, what we are going to inject is around 0.7 ml per kg. He must be weighing around maybe 30 kgs, so it will be 20 ml of this drug. And remember, if the needle is left by itself and you are getting contractions, then you can give the drug on your own. You don't have to do any manipulations. But if you need any manipulations at this point, then it's better to hold the needle till the end of the last few mLs, so that all the drug gets into the sheath and you get a good block. If you have a posterior cord response, the tunicate tolerance is more, but you have a medial cord response, the tunicate tolerance is less. It's almost 97% for the posterior cord response, and it's hardly 85 to 90% for the medial cord response. And hence, most of the times we go for the posterior cord response. But if you are not getting the posterior cord, you can inject few mLs of drug. I inject around 5 to 10 ml of extra drug if you're getting a medial cord response. You inject 20 ml, and she has injected in Ellicott's, and she aspirates all the time. I think she's being very well trained by everyone here, I think. 10 ml, 20 ml injected, okay. 20 ml should be enough for this step. Another 5, okay. So another 5 cc of this compound solution. I think here they combine both lignocaine and bupivacaine in one syringe. So usually I give it separately, but that's okay, that's fine, because the concentration doesn't go down. The only matter is with the pH value, but if you're taking it and injecting it immediately, this should not matter. Yes. So I remove the needle now, and you can see the direction of the needle, and you can see the depth of the needle. So it's 1, 2, 3, and 3.5 almost. And it's directed laterally. Don't direct the needle medially. You should direct it laterally all the time.
Maybe in an adult it's better to use 100.
Yeah, in adult it's better to use 100, but most of the times we have thin patients, and if you don't have enough on 100, this needle should suffice 5 mm, because the depth is not more than 5 centimeters in the infraclavicular fossa. But if you have obese patients, large, huge breasted women, then it's necessary to use a larger length, which is around 100 millimeters.
Sandeep,
Yeah.
I almost took the mic to ask the same question, because yesterday I told 100 millimeters and you told
Yeah.
50 millimeters was enough.
No, that was actually Dr. Bala's comment, that you should use 100 mm needle if you have a very muscular patient. Yeah, athletes and such kind of patients. Like yourself, Dr. Guru.
Yeah.
Hello.
Yes.
Sir, do you rotate the needle in different directions while giving the injection?
Yes, yes. You need to manipulate a bit inside. Once you get the lateral cord stimulation, which is the biceps,
No, no, my point is you aspirate after 3-4 ml of
Yeah.
injection.
you don't have to
Do
rotate.
you rotate the injection in different planes if it is to confirm that it is not false negative aspiration?
No, 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 not necessary. I did not get you. I mean, if you have some resistance, you rotate the needle.
No, no, no. Suppose in one direction the bevel might touch the vessel wall if it is in the vessel, and you get negative aspiration test, and you rotate in another direction and you get the blood when you aspirate. Do you rotate the needle?
No, no, no. Why you should not rotate the needle? I don't think so. It's necessary.
Then you will displace the needle, sir, from the facial sheath.
That is true.
And ideally, the bevel should be faced towards the plexus, so that the current which disperses from the tip goes to the nerve.
No, once you get the contractions, at 0.4 milliamperes, it is not necessary to rotate the bevel. As he has said correctly, it might displace the tip out of the sheath. So you have to be in the sheath all the time when you are giving the drug.
Any questions?